I'd like to invite Associate Professor Cliff Reid to give the plenary speech now. Dr. Reid is the Director of Training for the Greater Sydney Area Helicopter Emergency Medical Service and an emergency physician at Mona Vale Hospital in Sydney. Having trained and worked in emergency medicine, intensive care, and pre-hospital and retrieval medicine, he is interested in the provision of resuscitation and critical care regardless of location. His passions include teaching, human factors, and how to make things happen in critical resuscitation situations. Dr. Reid runs a popular blog, resus.me, for frontline resuscitationists. Off to you, Dr. Reid.
How do you follow Mel Herbert? It's crazy. Thank you very much for inviting me. It's a privilege to be here. It's an honor to share the stage with Mel Herbert, who's a superhero to all of us. And it's a delight to talk about emergency medicine being a great job. In a way, you've given me the easiest topic in the world. Now, I trained in the UK, I did the fellowship there. I came to Australia, I did the fellowship here. And in my travels, I've experienced emergency medicine in 5 continents. And I've been on a kind of quest to work out what the essence of emergency medicine is. And I think I reached a point where I did understand what that was, and I'll share that story with you towards the end. But in that time, I've realized that emergency medicine is a great job, and of course there are good things and bad things about every job. We've all been there where we've experienced the most amazing shift, where we've saved a life, where we got that wow feeling, that high five moment, where we know we've just made the biggest difference to a patient and that patient's family. We've given them the greatest gift that you can. We've saved their life. And there is no feeling like that. And we all know what that feeling is. But at the same time, we have those situations where we're faced with the access block, the busy shift, where you don't have time for a drink or a meal or a pee, where yours is the only car in the car park in the middle of the night compared with the other consultants. And you're trying to get things done, and you're faced with what I call sequential distraction, which is where you start to look at an x-ray that the interns asked you to view, but then the nurse in charge says you need to go and see the guy in bed 6, and then the admitting phone rings, and then a consultant from another specialty comes and wants to complain to you about something. And you never really claw your way back. And this tends to be punctuated by that final irritating step of a nurse slapping an ECG in your face, which is the optimal way to stop all cognitive processes. And I tend to find when this happens that I feel like I can't remember what I started doing in the first place, and I feel like I'm inside some kind of nested series of Russian dolls, and I've got to get out of them to go back to whatever that first job was. So there are tough things about our job, we all know that. But I still think it's a great job. And there probably is no perfect job. I used to think being an astronaut would be pretty cool, but I've since learned that it's not all spacewalks and medals, and in fact, it's not uncommon for their fingernails to fall off. So I wouldn't fancy that. Now, I'm going to give you a bit of awesome now with the first story, and this is when I was working on call as a retrieval consultant. I do a bit of retrieval medicine. And there was a bloke called Andy who was an emergency registrar doing a retrieval term. Now, Andy had gone off to a peripheral hospital to retrieve a young man in his 20s who had a diagnosis of septic shock due to pneumonia. And Andy calls me, and the conversation's something like this. He says, I'm near this guy, he's really sick, he's on quad strength adrenaline and noradrenaline, he's mottled, we can't move him. Every time we try to put him onto the retrieval stretcher, he loses his output. He's not going to survive the retrieval to Sydney. Okay, well, any other options, Andy? What have you thought of? I've done an ultrasound of his heart. Excellent. What does it show? I don't know how to do ultrasound. Okay, but I've MMS'd you the images. Well, cool, Andy. What do you think it shows? I think it probably shows tamponade. Well, you're right. You've done a good parasternal long axis there. There's right ventricular diastolic collapse. There's pericardial fluid. Excellent. I thought it was tamponade. I'm ready to do a pericardiocentesis. I haven't done one before, but I'm pretty sure I know what to do. I've got the equipment ready. With your say-so, I'll crack on. By all means, it sounds like a good idea. So Andy aspirates a pretty large volume of straw-colored fluid, and before they leave that hospital, that guy is off all vasoactive drugs. He's pink. He has a normal blood pressure. which is why Andy looked like this immediately after the procedure. Now that was really cool, and what he showed there was really what emergency medicine's all about. He wasn't going to let that patient die. He wasn't going to be held back by a lack of a certificate of competence in ultrasound. It wasn't going to be held back by the lack of other specialists that could come and bail him out. He took responsibility, he owned that resuscitation, and he made things happen. That was awesome. And I think Andy there showed something of the spirit of emergency medicine. And that spirit was possessed by our forefathers many years ago, who realized that it was unsatisfactory having these front of house units where the sickest patients were dealt with by the most junior staff, and they sought out to change that. And it was really interesting because throughout the English-speaking world, there was kind of a convergent evolution. And the key year was 1967. And in 1967, everyone was having a good time. They listened to really cool music. And they wore really nice clothes. And some people were lucky enough to fly the X-15 rocket plane, which at more than 7,200 kilometers per hour remains the fastest manned flight ever made to this day. So what was happening around the English-speaking world? Australia appointed its first director of an emergency department who was full-time. The Americans had their committee on emergency medicine for the first time. And in the UK, the forerunner of the College of Emergency Medicine, the Casualty Surgeons Association, was created on the 12th of October, 1967. That's an important date to one person in this room. That happens to be my birthday. This is my birth certificate. I was born on the same day as UK Emergency Medicine. That's irrelevant to any of you, but it makes me really happy. And what it also means is that we've been doing this a while, and it puts pay to any patronizing suggestion by other specialists that we're involved in a young discipline. I'm not that young. We've been doing this for half a century almost. And that's why, we do it pretty well, and that's why politicians and managers and other specialists shouldn't be telling us how to do it. So I think it's a great job, but it's only a great job if it's enjoyed by the people who do it. And it's only a great job if the people on the receiving end get a good deal, if it's good for patients. So let's look at those factors. I asked some of the other doctors in my department why they do emergency medicine, why it's good. Here's some of their responses. Emergency medicine is a challenge. Every day is a challenge. Even the difficult psychosocial stuff makes us better doctors. It pushes us. It's the kind of thing where we will never be comfortable. We will never feel on top of our game. Emergency medicine pushes your communication skills. It's a real challenge to go from a demented old lady to a frightened child to an angry relative and rapidly adapt your communication techniques. And I find this really helpful in real-world situations, like when I have to deal with a nutter on the bus. Emergency medicine can be done anywhere, up a mountain, on a ship, in a helicopter. That's why when you're on a plane and they call for medical help and a dermatologist volunteers, you know you have to get up and do something quickly. Emergency medicine is about fixing sick and injured patients. This is real medicine. Emergency medicine invented foam. I like having random Tuesdays off. That way I can go to the beach and it's not full of all the 9-to-5ers. Emergency medicine is a ticket to travel and work around the world. Patients and the general public respect what we do. They know we don't earn big bucks. They know we work shitty hours, but they value the service we provide. Emergency medicine is real teamwork. In what other specialty is it routine for the consultant to often be addressed by their first name by the rest of the team? This isn't just good for team spirit and mentoring. This flattens authority gradients and enables safer communication around patient care. Excuse me. My friend, emergency physician in the UK, Dr. Howard Simpson, describes medicine as a pie. This is the pie slice model of medicine, where every acute specialty is a slice of that pie. And where does emergency medicine fit on this? It overlaps with all of them at the sharp ends of the pie. The interesting bits, the acute bits, the bits with the juicy filling. And as you go further and further out towards the periphery of that pie, you just get more and more pastry. And that's why, as one of my colleagues said, he reckons deep down, every other specialist secretly wishes they were able to do what we do. So I go back to the UK quite a lot, got friends and family there, and the media recently has not stopped reporting the desperately dismal situation there in emergency medicine. Consultants emigrating in droves, unfilled training posts, and this relentless onslaught of more and more patients each year. So I went back to the UK just a couple of months ago, and I arranged to meet up with some of my old colleagues. And the plan was to go out for a proper British curry and talk about stuff. And I was expecting it to be a bit depressing, to be honest. I thought they were all having a bad time. And yeah, they did say that things were tougher than they'd ever been at work. But they were their same happy selves. They were the usual upbeat, zany, wacky people that I'd always known. That's from that night in the curry house. And I came away really, really enthused, really reassured that they're still happy. But I started to wonder, why is it so bad there and yet they can remain so happy? Is it because emergency medicine's great? Is that why they still like it? Or are they deluding themselves? Are they just using some of the cognitive biases that we've evolved to protect ourselves, to stop us going crazy? Perhaps it was the sunk cost fallacy. Now this is when you've invested so much time and resource into something, you don't want to let it go for fear of losing those resources, failing to realize that you've already spent them. It's been suggested that this is maybe one reason why people stay married. Or maybe it was choice supportive bias. So this is when you've been forced to choose between a few options, and after the event, because you've chosen one particular option, you then convince yourself that that was definitely the best option. Some people say this is why if you've spent a couple of $1,000s on a Windows computer or a Mac, you're never going to go to the other side and you'll absolutely not entertain any discussions about the relative pros and cons of these things. So you like it because you chose it. So is that the case here? You know, do we think emergency medicine is a great job because we chose it, or did we choose it because it was a great job? I'm not sure. Does it matter? Well, maybe it does. Maybe we would have been happier if we'd chosen something else. Maybe if I'd become that eye surgeon and earned all that money, I'd be happier. But the evidence suggests that's probably not the case. There's studies that show that once you hit an income of around 75,000 US dollars a year, that any incremental increase in salary doesn't make you happier. There's also a thing called the over-justification effect, which is when you are given a bigger and bigger reward for doing a task, there's less intrinsic motivation for doing that task, and you enjoy it less. So I'm talking a lot about happiness and what makes people happy. And do we need to? Does it matter whether or not we're happy? Let's look at the science of human happiness. Now, I've researched this extensively with my team, and I've looked into it. And what I've come up with, having looked at the literature, is that it is actually worth being happy. It makes a difference. Humans who are happier have better lives in a number of different domains. So let's look at the science of human happiness. What makes us happy? Well, an interesting thing is that we're all born with a genetic set point that determines your chronic happiness level. And this set point determines about 50% of your chronic happiness. And there's nothing you can do about that. If you were born sad, you'll stay sad. If you were born happy, you'll stay happy. So what else can we do? What about our circumstances? Whether you're married or single, live in a sunny country or a rainy country, rich or poor, even sick or healthy. Surely your circumstances are going to determine your happiness. Well, apparently that only makes up 10% of your chronic happiness levels, your circumstances. And this is amazing, but it's true. And this is because of the human capacity to adapt. We show adaptation in all aspects of our neurology. The same way you can sit on the toilet for 30 minutes reading EMA, but the next person that comes into the bathroom will gag uncontrollably. That's sensory adaptation. We also have something called hedonic adaptation. There's the hedonic treadmill. You buy a new car, you get a nice house, you move to California, you're happy for a short period of time, but then your brain moves you back, the treadmill moves you back to the happiness levels that you had before you made that intervention, the hedonic treadmill. And that adaptation is good, that protects us. It keeps us from going crazy when our circumstances change adversely. All right, 50% genetic set point, 10% circumstances. What's the rest? This is the good news. The rest is your intentional activity. So these are things you can do. Circumstances are what happen to you. Attentional activity is what you can do in spite of your circumstances. This is an active process. In other words, stuff doesn't make you happy. Experience makes you happy. Doing stuff makes you happy. So owning that ENT surgeon's AMG Mercedes would not make you happy. Hot wiring it, going through some speed cameras and burning off the tires doing donuts in a car park probably would make you happy, an experience. And what are the intentional activities? Well, there's gratitude, kindness, and setting goals. The attitude of gratitude, being grateful for all the good things in our lives, makes us happy. Being kind to other people, particularly when these acts of kindness are at some expense to ourselves in terms of our time or our resources or our energy. That makes us happy. We're social animals. We need to connect. And then setting goals. And these goals are about improving ourselves, but in a way that's in keeping with the kind of person we want to be. So these are self-generated and self-concordant goals. These are the three things. So emergency medicine is perfectly capable of making us happy. It has all the ingredients there. But the other thing I mentioned was, for it to be a great job, it's got to be good for patients. Is it? Let's take an extreme example. Let's imagine there's no emergency medicine. Let's imagine this is France in the 1990s. I went on a skydiving holiday when I was an ED registrar to the south of France. And one member of our party sprained his ankle. He didn't land heavily, he landed awkwardly, and then while walking forwards, rolled his ankle. I examined him, he was still able to walk. He had no bony tenderness, he had minimal tenderness or pain over the lateral ligament complex of his ankle. I said to him, I think this is a sprain, you probably should ice and elevate this, and we'll have another look tomorrow. But a helpful bystander had called an ambulance because he was insured. He said, well, why don't I go to hospital and get checked out, but come with me if you like. I said, okay. So we went to this hospital. It was really lovely. It had doctors' names on plaques on the wall. It had tinted windows and plastic plants, and it was really, really, really quiet, this hospital. And a friendly nurse greeted this guy and said, I'll organize an x-ray and call the orthopedic surgeon. Does that stuff. The orthopedic surgeon comes down, looks at the x-ray, and says, you have a fracture, you need a cast. So I had a look at the x-ray, and I said, hope you don't mind, but clinically I don't think there's a break, and doesn't that look a bit like an artifact, this longitudinal lucency and the distal fibula? Could that be artifact in view of the clinical findings? No, it is fracture, it needs cast. So, okay. So he gets the cast, he's on the crutches, his holiday's over, and he goes home. And this guy had the decency to email me 3 weeks later and say, you know what, they took the cast off and they did some more x-rays and they examined me and they said it was definitely a sprain. I hadn't broken it. Sorry about that. Thanks for your time. And that was interesting. Had the orthopedic surgeon done anything wrong? We could easily criticize him for not examining the patient. But in a way, no. What that system missed was someone that can deal with an undifferentiated patient, someone whose career it is to make these calls. Had any decent nurse practitioner or ED registrar examine that patient, they would have applied a validated clinical decision instrument, conclude that patient doesn't need an x-ray, doesn't need an orthopedic specialist, and none of that stuff would have happened. But once faced with an orthopedic referral, he had orthopedic management. And we all say that to a man with a hammer, everything looks like a nail. And of course, most orthopedic surgeons are men with hammers. So when emergency medicine doesn't exist, I think there's this unquantified cost, this unquantified inconvenience and misery and pain to patients. If you think about where we sit in the healthcare system, we protect patients from the rest of the healthcare system. And we also protect the rest of the healthcare system from all these inappropriate patients. That's an amazingly important job. It's got nothing to do with resuscitation, but it's a really, really key, important part of what we do and why it's a great job. Now here's another example of why it's great for patients. A guy comes in, he's in his 60s, he's got dyspnea and hypotension. He's got cardiogenic shock. The emergency physicians try non-invasive ventilation, but he remains hypoxic, so they're going to have to do a rapid sequence intubation. They speak to him and they say, you know what, we're going to take away all this breathlessness for you by giving you an anesthetic and you'll go off to sleep. You'll feel a lot better and we and our colleagues are going to try and fix your heart. But there's a serious risk that we're not going to be able to. Your heart's very damaged and you need to understand that you may never wake up. In a moment, we're going to bring in your wife and 2 daughters. Do you understand? I want you to remember this conversation when they come and speak to you. And he says, yeah. So they then go out and they say the same thing to the family. Do you understand? Yeah. Okay. Remember this conversation when you go in and speak to him. So they go in, and they have 5 minutes together as a family. They cuddle, they declare their love for each other, they have a few laughs and jokes, there are tears, they thank us, they go out the room. He gets his RSI, he goes to cath lab, he goes to ICU, and he subsequently dies on ICU a few days later of multi-organ failure. No surprise there. So what did we do? We did a cool resuscitation. It didn't make a difference to the patient. But the other thing we did is we enabled that family and that patient to say goodbye. And that might sound like small consolation, but for those of us who have lost loved ones and didn't get that chance, it's an immeasurable act of kindness, an incredible gift. We should never forget the power we have to enact or withhold those acts of kindness. That's where we stand in the system. That is so important. So, I've been a doctor for a while, and I did my first emergency resident job 21 years ago. And I'm still enjoying it, so maybe I've got some stuff to share to people that haven't been around so long. So here are the tips. It's an evidence-based guide to staying happy. Remember the gratitude, kindness, and goals. So be grateful for what you have. We do an amazing job, often in amazing places with amazing people. Most of us only work 40 hours a week. We get pretty good pay. We're well looked after. And we're valued, we're appreciated. We are there at a point in people's lives when they most need a doctor. What a privilege. We should be grateful for that. But then when we come home, we've got to remember that the job we do enables us to see life and death and the thin line between them, that fragile line between them, through such a lens, with such magnification, that we can't fail to appreciate how lucky we are to have our health, to have our loved ones still. We have to make the most of that. We have to have that attitude of gratitude. And we should never stop being kind. Never forget that person on the end of the needle or the end of the laryngoscope. That person who's every bit as amazing and complex and interesting as you are. Being kind, that element of giving, will keep you happy and will keep them happy. And of course, setting realistic goals, but goals that will make us better people. Goals that might be professional, they might be educational, they might be academic, but something to aim for each month, each year, so that you progress in the career and you carry on loving it. Another interesting finding in the literature about these intentional activities is that when they become routine, they are less effective. You adapt to them. So they're more effective if you do them at varied times and at an optimal frequency that isn't every day. And what I'm hinting at here is I'm commending part-time working. Emergency medicine is a great job, but there's no shame in not wanting to do it every day. All right? It's healthy. It's healthy to do other stuff. And if we didn't, we wouldn't have retrieval medicine or toxicology or PEDS-EM or emergency ultrasonography or the teaching and academic stuff that goes on. It's because people are prepared to do other things with their time that we're able to expand emergency medicine. And that comes along to another recommendation I want to make. And you might not agree with this, but many people are in the habit of calling themselves ED doctors. I work in an ED, but I'm an emergency physician. There's no other specialty when you think about it that defines itself by the physical confines of the workspace. We're more than emergency department doctors. And you have to remember that with arbitrary time-based targets coming in, if you limit your expertise to the ED, you're going to be limited by both time and space. And I think that's a shame. I think that undervalues the contribution we can make to patient care. It undersells what we can do. It undermines our expertise. We need to learn to overcome these limitations of time and space, to transcend these time and space limitations. Okay, I said I would share a story with you about when I think I hit upon the essence of emergency medicine. Some of the details here have been modified to protect the humble, but it's my story to share. I trained in the UK, as I said. I completed training in emergency medicine. I trained in intensive care medicine. I trained in pre-hospital care. And people kept saying, when are you going to get an emergency medicine consultant post? And I said, I still don't feel ready. It's still stuff I want to learn. I'm going to go to Australia and do paediatric critical care for a year. So I came to Sydney. I did peds emergency, neonatal critical care, peds and neonatal retrieval, paediatric intensive care, and loved it and learned so much. And finally felt confident. And I was ready to go home. I'd even accepted a consultant post in the UK. And then some annoying Australian people said to me, you know, your exam back there is not very tough. Our fellowship here at this college is much harder. It's like, when you're walking away and someone calls you a coward and you have to stop and turn around and go, okay, all right, I'm going to stay here a little bit longer and sit the fellowship and shut you buggers up. So I went and did some general emergency medicine in a busy place and worked for the fellowship for a few months here, which was tougher. And during that time, we had a particularly malignant shift where everyone was just dying around us. And my boss, A-Face-M, asked me what I was doing. And I said, I'm referring this guy to cardiology. He's got chest pain, ongoing dynamic ECG changes. His BP's a bit ropey. He needs to get to cath lab. Yeah, I know that, boss. I'm calling cardiology. They haven't called back yet. Okay, well, when you're done, meet me in resus. We've got a couple of major traumas coming in. No problem. While I'm sitting by the phone, I hear a mother scream out, my son's not breathing, my son's not breathing. So I run to the bed space, grab a bag valve mask, start bagging him, ask a nurse to help me wheel that bed round to the remaining resus bay. While I'm doing that, I get a quick history from the mother. This boy has had a ventriculoperitoneal shunt in place since infancy. He was now about 10, 11 years old. He had headaches for a few days and had presented to the local children's hospital, but had been sent home. It got worse and worse, so he had come to the local hospital. While waiting 6 hours to be seen, he'd become increasingly drowsy and stopped breathing. Wasn't looking good. Quick primary survey revealed he was apneic, he was bradycardic, and had dilated, unresponsive pupils. This kid had coned. In my mind, this kid is almost certainly dead. We're in resus. The boss said, what have you got? And I said, a kid with a VP shunt, presented with headaches, he's now apneic, and he's got signs of herniation. And that was like hitting a switch. The boss, the face-M, said, intubate him and hyperventilate him now. You get neurosurgery down here. You give me, we'll see, about 30 kilos. Give me 150 mils of 20% mannitol now, that's about a gram per kilo, and give me a 20 mil syringe and a blue needle. This all happened really quickly. I intubated the kid, started bagging. The boss stuck the needle in the shunt reservoir, started aspirating CSF while checking the bag of mannitol with the nurse, saying, squeeze harder, squeeze harder. Cliff, you need to bag a bit more vigorously than that. We need to make some space in there. The neurosurgeon walks in. The boss says to her, this kid's got a blocked shunt, needs to go to theatre. You don't need to see him, we'll bring him to you. Amazingly, the neurosurgeon nodded, did a 180-degree turn, and walked out of the room, said, I'll get theatres ready. The child then started coughing on the tube. We had to sedate and paralyze. I rechecked the pupils were coming down. They were reacting to light. We went to CT. The child had a shunt obstruction due to a fractured shunt at the level of the neck. Went to theatre, had revision of the VP shunt, and went home neurologically intact. Obviously not that day. And while this shift is still going on and I'm hyperventilating, the kid's coughing, we're drawing up some drugs, I'm sort of reeling. The boss is calling out orders to the trauma team to manage these trauma patients and says to me, did you get that guy to cath lab yet? Oh, him? No, I haven't spoken to cardiology yet. Well, he's pretty sick. You need to get moving on that. Sure. Now, that emergency department had a milkshake machine in its coffee room. And it was a long drive home. I was always knackered at the end of a shift. And I would always make myself a milkshake and just sit and review any learning points and chill out a bit. At the end of that shift, I had 3 milkshakes. I couldn't get up and go. There was something bothering me. There was something bugging me. There I was, 10 years out of medical school, trained in all these critical care disciplines, feeling confident, feeling quite near the top of the emergency medicine ladder. And what I'd just seen had blown me away. What I'd just seen defined emergency medicine in a way that I'd never experienced anywhere I'd ever worked. And there was no one procedural component of what was done that I couldn't have managed. You know, in an exam, I would have answered the question about what you need to do for raised ICP. I'd have got good marks. But there was more to it than that. There was this essence of emergency medicine, this ability to make things happen, to be 2 steps ahead, to control the rest of the team, to stay ahead of the disease, to stay ahead of death, to save that child's life. And I was convinced, absolutely convinced, that it was the emergency physician that made the biggest difference. It was emergency medicine in its purest form that saved that boy's life. And I was also convinced that had he presented like that to anywhere I'd ever worked, teaching hospital, pediatric hospital, whatever, he would be dead. I'd never seen it done like that before. And I concluded I wasn't on anywhere near the top rung of the ladder. I concluded that that was the first day I'd been shown the ladder. And now I needed to get on the first rung. So to me, that's the essence of emergency medicine. I've presented a number of reasons why I think emergency medicine is a great job. I know you agree with me. That's why this was an easy talk to give. So, I want you to enjoy yourselves this week. You do a great job. This is a great college. It's going to be a great conference, and it's happening in a great city. So, be happy. Thank you.